You're listening to The Revolution of Regenerative Medicine, a podcast with me, Dr. Gregory Laurence. So on the topic of death, why do we die typically if we're healthy at somewhere between 70 and 100 years old? We really don't know. There's a lot of scientists that strongly believe there's nothing about our cells in our bodies which should dictate that we should die at that point. We just know that somehow they wear out. If you look at death the way I look at it, there's from a cellular surgery standpoint, the main death that I can't do anything about or have an effect on is like death by flyswatter. If you get hard enough with something big enough, you're going to die, and there's probably nothing I can do about it. But all the other areas in which patients have typical courses of death seem to be something that's going to be amenable to cell surgery and stromal vascular fraction. Those examples would be, if you think about people who die of heart disease or of lung disease or of brain disease, we a lot of times think in terms of single organs that kill people, that wear out, and that certainly is true. But very rarely is that one organ the only one that's involved. Usually it's a multi-organ failure, and one of them is more predominant. But if you think about it, an organ's made up of cells, and whatever has caused that organ to become compromised is something that should be able to be replaced. And if you look, for a lot of times, and I know we were taught this since we were kids, that you're born with a certain number of brain cells, right? And you're never going to grow another one. And if you have and it's turned out that we were wrong. We've had scientists that have found places in the brain where they have cells, and they've been able to tag those, and those will migrate long distances across the brain when there's an injury. So we know that there's these pluripotent cells in the brain that are ready to heal up issues with the brain, but everything in life is about homeostasis and balance. And if you've got more negative things than positive things, then things are going to go in the wrong direction. So the question is, how can we affect these tissues and these organs? And one of the things I'll just mention that's been a little bit of a disappointment is we would love, with using this cell surgery technology, to replace the cells that make insulin, because we know some diabetics don't have any of those cells. It's called type 1 diabetics. And then the type 2 diabetics, in general terms, have cells that are producing, but the sensitivity to insulin is reduced. And so we're trying to find all kinds of different ways. So there's not a lot of promise yet for diabetics, but the real promise for diabetics is that the real problem with diabetes is the multi-organ insult that there is in anybody who's a diabetic due to the loss of microvascularization and other cell changes. And the cool thing for diabetics is that stem surgery has been shown to have positive effects on just about all organ systems. So we might not be able to yet do very much about the primary disease in that particular area, but we are able to have multiple effects on all the organs of the body, or most of the organs on the body. So the other thing that I wanted to talk about is death is just environmental forces, DNA damage. There's a lot of talk right now in the anti-aging literature of shortening of the telomere, and once your telomeres get down to a certain length, you lose the ability to for the cells to go on, and people die, or the cells die. There's a process called apoptosis, which is when cells go through the normal dying process, and if they're replaced by cells that are there, then the organ survives and the organ continues to function well, but if they're not, it doesn't. So the question is, can we manipulate these normal balances of healing and disease? So where does cell surgery fit in, and where doesn't it? Well, one of the main things to understand is that transfusion is everybody's familiar with transfusion. For either your own cells were taken out and given back to you, or through maybe a matched donor, you were transfused blood. So actually getting tissue from another human being is not the craziest thing, right? It used to be crazy, but now we've got whole organs that are donated from patient to another patient. we have the situation where your own tissue is either banked or in some other way given back to you. And those terms are called autologous tissue if it's your own. If it's from somebody else, it's an allogenic or an allograft. And we definitely assign a lot higher amount of safety if it's your own tissue. Secondarily, if it's from a close relative human that matches, and then a distant human in some situations is appropriate. And then, there's even a lot of talk about using, like I mentioned a while ago, some tissues from different types of animals that can still be helpful. So the neat thing is to recognize that your own cells might be the safest and the ones that make the most amount of sense. Again, we haven't figured this out completely. We're engineering cells, we're expanding cells, meaning we're taking cells out and they're growing them out in a lab. And these are all different ways that we're going to, in the future, very likely be able to have a really, really big effect on human disease. Thank you for listening to this episode. Be sure to subscribe to my podcast, The Revolution of Regenerative Medicine. I'm Dr. Gregory Laurence, and I look forward to you joining me again soon.